here what can you see if you compare the right hila with the left hila? What happened? This is the concave orientation or configuration of the right hila. This is normal. What happened over here? Here it is concave, but again here it is convex and somewhat showing spiculated margins. So these are basically the lymphadenopathy along with some tumor. Then don't forget, when you are seeing the chest x-ray, don't forget the bones. Always look at the bones. This is the right clavicle, and we have already described the rotation, the distance between the spinous process and medial end of the clavicle, the posterior ribs, and then the anterior ribs, the scapulae. So all these things you need to see. So here what's going on? There are discontinuity and fractures, multiple fractures of the left ribs. And then comes the humerus. You need to see or check the corners of the film. Always there must be some hidden pathology over there. The acromion, the acromioclavicular joints, the glenoid cavity, suprascapular notch, axillary border of scapula. Then what's going on? Don't forget the spine by looking behind the heart, seen behind the heart. So here is an scoliosis of the patient, the thoracic scoliosis, which is centered at the mid thoracic vertebra, which is showing concavity towards the left. So all this because of the scoliosis, the ribs are showing crowding on the left. Then again, don't forget to see the clavicle, as we have described, the clavicle fractures are being depicted. And always look at the bases of the lung, below the diaphragm, to see the pneumoperitoneum or anything, any abnormality which is causing the abdominal pain, or which may radiate to the chest. So patient may present with the chest pain due to abdominal pathology. So don't forget to look at the abdomen below the diaphragm. So here again a patient, here you see what's there. There's free air under the right and left hemidiaphragm. So this is a pneumoperitoneum, which is an acute emergency. Patient must be settled, patient must be rushed immediately towards the surgical department. Another patient in which you need to see what's wrong here, that there's an excessive amount of air within the soft tissues, intermuscular planes of the soft tissues. So basically this is insufficient emphysema. So these are the review areas. You have to check the apices, the hila, retrocardiac, the heart, behind the heart. There must be some hidden pathology sitting behind the heart, mostly the mediastinal or maybe the left lower lobe collapse or under the diaphragm. Now coming to the common chest emergencies. So the pneumothorax, the most important emergency which we routinely encountered. So here the deep sulcus sign is being evident on this x-ray. So what's if you compare the left side with the right side, air is tracking down the claustrophrenic angle, and claustrophrenic angle has reached a bit lower down as compared to on the left side. So this is a very pathognomic sign for the pneumothorax. So what happened, usually patient, we are dealing with peds patient, so patient is unable to stand. So what happened, patient is lying down, so air is a lighter medium. It usually trickles or accumulate along the right cardiophrenic angle adjacent to the this is the pleura, this is the lung surface. Lung is being displaced towards laterally, and air is trickled medially. So this is again a presentation of a pneumothorax in children. And how would you confirm that? You may ask the patient to sit in left lateral decubitus position. So what happened, again air is a lighter medium, it will go up. So here you can easily discriminate the air or confirm your pneumothorax. And this is an adult patient, and for the sake of understanding I put it here. This is the collapsed lung and the excessive amount of air. This is the deep sulcus sign again, and there is shifting of mediastinum towards right. So this is a tension pneumothorax, again a big emergency. Patient must be rushed to the surgical department, chest department. Then comes this x-ray. Here you see easily the collapsed lung, left lung, and then excessive amount of air, free air within the pleura. This is another tension pneumothorax. This is air, this is a lung, and here intubation has been done. Tube is sitting within the parenchyma, its repositioning is suggested. There is a mediastinal shift. ETT is also seen placed. On the left lung, there is a big consolidation with air bronchogram. Now coming to the pneumomediastinum, here the air is seen within the mediastinum. This streaky amount of air lucencies are seen within the mediastinum on both sides, and also trickling along the pericardium, within the neck region, the axilla, all the way around. So this is the pneumomediastinum. So here we have already described about the thymus, which is a normal entity in peds. Here what's wrong, basically this is again a sign of pneumomediastinum, that is an spinnaker or angel wing sign. The air is surrounding this thymus on both sides. So this is it is mimicking just like this spinnaker. And what happened here, that pneumopericardium air is surrounding the heart, and it's seen within the pericardial sac. So it is causing compression effect over the heart, the tamponade effect. So patient may have muffled heart sounds or some serious kind of emergency. Then don't forget to see the foreign body, and don't forget to suspect the foreign body in each and every X-ray of the child. Whenever you see the discrimination of densities on both sides, one side is more blacker, one side is less, then always think of foreign body. So how would you confirm your foreign body? So, not all the foreign bodies are radiopaque. Some are radiopaque, that are easily seen, but few are radiolucent. Most of the time they are radiolucent, the rubber, the batteries, the button and peanuts. So most of the time they are radiolucent. So what happened? How would you confirm? You can confirm these by expiratory view. You ask the patient to expire out. So what happened? The air being trapped on that side in which the foreign body is present. So here the foreign body is on the right side, and here the foreign body on the left side, because the air has been trapped on expiratory view. But in children, basically what we can do, the expiratory views are not possible because the children are non-cooperative. So we can ask them to again do a lateral decubitus view. Now here the foreign body is on the left side, so we ask the patient to lie in a left lateral decubitus view. So what happened? Air is during a left lateral decubitus view, air is being tracked outside normally, but here air is trapped. Here this is the normal side, air has been tracked outside, and this is the normal lung. But on the abdominal side, air is being trapped inside. There is a ball valve phenomena, air is being coming in and it's not going out, it is being trapped. Then comes the pleural effusion. Whenever you see the complete whiteout of the lung, then most of the time about 5 liters of pleural fluid are present. So pleural effusion is again a very important sign. We can confirm it further on ultrasound, and from ultrasound guided aspiration. Then we go for DR, and then for proteins, especially to look for the transudate and exudate. Coming to the pulmonary infections, now these are the radiographic patterns recognition from which forms the cornerstone for the successful X-ray interpretation. And the most common causative organisms are viruses, the bacteria, Mycoplasma pneumoniae, Streptococcus pneumoniae, respiratory syncytial virus, Mycoplasma pneumoniae in atypical infections. The radiographic patterns are lobar, the bronchopneumonia, and interstitial pneumonia. Lobar pneumonia usually involve one or more lobes, and bronchopneumonia is the consolidation involving the pechi, and it's centered around the terminal bronchioles. The interstitial inflammation is confound within the alveolar walls, the interstitial spaces. This is the bronchopneumonia. Here you may got the pechi infection and across the lobe, and here the complete lobe is involved in case of lobar. And these are the diagrammatic illustration for the pathologies of the lung. The consolidation, it can be in the form of mass and a nodule, nodule you have a smaller size as compared to mass. There may be some lung collapse which is labeled as atelectasis. There may be some interstitial thickenings due to pulmonary edema, the pulmonary hemorrhages, or maybe some alveolar proteinosis or malignancies. Then the Silhouette sign, this is very important sign. Normally there is a contrast between the air-filled lung and adjacent soft tissues like heart and left hemidiaphragm. When air is replaced by abnormal fluid, the pus cells or inflammatory exudates, then this interface is lost. So it is representing as Silhouette sign, and it's a very handy sign for localization of the pneumonia. So let's describe what happened here. Here you may not see the left heart border just because the consolidation is sitting in lingular segment of the left lobe. That's why the left heart border is being silhouetted by that consolidation. Here what happened, left heart border is normal, but the left hemidiaphragm is not well defined as seen on right, just because of consolidation sitting in the left lower lobe. So because of this consolidation, in this way we can localize the consolidation where it is. Here it is in lingular segment of left lung, here it is in left lower lobe. So let's see an example. This is a 10 years old female with fever and cough. What happened? Again, the left heart border is not well seen, left hemidiaphragm is well seen. So again, this is a consolidation in lingular segment. Then this is a diagrammatic representation of another patient. This is a 8 years old, 1 week of fever and cough. So what happened? Left hemidiaphragm is a bit hazy, as well as the left heart border. So again, the consolidation in both left lingula and left lower lobe. Here the right heart border is obscured or silhouetted. So what happened? It is in right middle lobe, which is being very well seen in the lateral view. The oblique fissure and the right horizontal fissure are being it is confined, the consolidation is confined by right horizontal and the oblique fissure. Now what's wrong going here, that this is the left hemidiaphragm, the normal left hemidiaphragm. The right hemidiaphragm is completely gone, and left heart border is there. So it means this consolidation, excessive amount of consolidation, is sitting in the right lower lobe. Here this is the right horizontal fissure, so consolidation above the right horizontal fissure is always in the right upper lobe. You can also confirm on the lateral view. And this is a classical bulging fissure sign which is seen in Klebsiella pneumoniae. There is excessive amount of pus is being secreted by this organism, and you may find the convex right horizontal fissure rather than this is the normal position. And then comes the air bronchogram sign, which is a tubular outline of airway made visible due to filling of the surrounding alveoli by fluid or inflammatory exudate. So basically this is a patient of RDS, intubation has been done. This is a neonate which is preterm. What happened, the both lungs, there is a surfactant deficiency. So what happened, the both lungs are whiter, the opaque, hazy opaque, and this is the air within the bronchi which is seen. So this is called air bronchogram sign. Another example, what happened, there is a lobar pneumonia, left upper lobe and left lingular pneumonia, and all these are the whitest opacities are consolidation, and air is seen within the bronchi in a linear fashion in a branching pattern. So this is an air bronchogram sign. Again, air bronchogram sign. So radiographic, now discuss the radiographic features of bronchopneumonia. Multiple small nodular and reticunodular opacities which tends to be patchy and confluent. These represent areas of lung when there are patches of inflammation separated by normal lung parenchyma. So this is a classic example for the bilateral non-segmental consolidation in lingula. This is the lingula and the right upper lobe, perihilar. You may see these are the linear shadows, these are the nodular shadows, multiple kind of shadows. So this is not a lobar variety. This is bronchopneumonia, which is most commonly seen in viral and a few bacterial pathologies. So again, another patient of bronchopneumonia, the confluent parenchymal consolidation with diffuse bilateral pulmonary involvement. Then comes the interstitial pneumonia. As I've told you, this is the thickening of the there is a thickening of the alveolar walls and interstitium of the lung, not involving the alveoli themselves. So it may be seen as a interstitial thickening, as the linear reticular markings in perihilar, hilar region. Here you may see. and this is most commonly seen in the mycoplasma pneumoniae or maybe the pneumocystis gyrovesi like infections. The mycoplasma pneumoniae, this is a case which shows ill-defined opacity in left lower lobe. Here you may easily appreciate. Then comes again another patient. You may see these are the bilateral perihilar reticular opacities, more at the right lung base. Another patient of mycoplasma pneumoniae, you may see these are the perihilar opacities. Then comes around pneumonia, very interesting entity. What happened? It usually simulate a mass lesion, and the proposed theory behind that, why it's occur in children, because children lack usually children have underdeveloped channels, like underdeveloped channels, uh, underdeveloped interalveolar communications and collateral airways. So when they develop, they allow air drift between parenchymal subsegments. So infection dissemination occur throughout a lobe, leading to a lobar pneumonia. So usually due to lack of these channels, the infection is confined and it is depicting like a mass. It doesn't show sometimes the air bronchogram. Usually it happened up to the age of 8 years. So here is a good depiction of the round pneumonia. There is a rounded opacity which can be mistaken for a mass, but remember this is a round pneumonia. So don't follow this patient after having an antibiotic course. Then this is another patient having round pneumonia. Then comes the lung abscess. Whenever you see an F fluid level within a cavity in a lung, always think of lung abscess, and don't forget to get an additional view of lateral view to confirm whether it's a lung abscess or empyema. And then another thick walled cavity showing air fluid level, again multiple radiculonodular shadowing, multiple patchy consolidations. So this is again a lung abscess, sorry. Now finally the tuberculosis, which is very important infection and endemic situation in our country. Location, that is a primary infection can be anywhere in the lung in children, whereas there is a predilection for the upper and lower zones in adult. Post-primary infection have a strong predilection for the upper lobes because of oxygen tendency of this bacterium. Then comes the miliary tuberculosis, which is evenly distributed through the both lungs. We have three radiographic features or patterns: the primary TB, post-primary tuberculosis, and then comes the miliary tuberculosis. The primary tuberculosis consists of the bone focus, which is a tuberculoma, granuloma, caseating granuloma. Usually it is calcified along with the lymphadenopathy. Here you see this is the hyla, bulky hyla, the convex outer margin, and this is a consolidation as we just discussed in earlier. So these are both are called the bone focus. You may find these granulomas also in this patient. Another patient of primary TB, the same thing are being depicted. Then comes these granulomas, the rounded, lobulated, soft tissue densities within the chest. The most striking finding, especially in children, is that of ipsilateral hilar and contiguous mediastinal paratracheal lymphadenopathy, usually right-sided. This pattern is seen in over 90% of cases of childhood primary TB. Pleural effusions are more frequent in adult. Calcification of nodes is seen in 35% of cases. When a calcified node and a bone lesions are present, the combination is known as Reinke's complex. So this is again a good demonstration of a well-defined, rounded, soft tissue, partially calcified, seen in left mid-zone, and it is again it's not a malignancy, it's a bone focus. Then comes the post-primary TB. The hallmark of the post-primary TB is the cavitation. You have to see the cavitation, and it has a tendency for oxygen, more oxygen dependent parts like posterior segment of the upper lobe and superior segment of the lower lobe. So the typical appearance of post-primary TB is that of patchy consolidation, linear and nodular opacities, cavitations 40% of cases with endobronchial spread, which is showing the tree in bud configuration on the CT. Now here you see this is a granuloma in the left upper lobe showing internal cavitations. So this is hallmark of, and it's in the upper lobe, so this is hallmark of post-primary TB. Then comes the miliary pulmonary tuberculosis. It represents the hematogenous dissemination of an uncontrolled tuberculous infection. It is seen both in primary as well as post-primary. So these are mostly 1 to 2 mm randomly scattered nodules with no zonal predilections and no calcification. So this is a good depiction of the miliary tuberculosis. Here you see the fine, very fine nodularity. It is randomly scattered in both lung fields. No zone is spared and there's no zonal particular predilection. Now finally, don't forget the novel coronavirus, as it's a current pandemic situation. We are all having this situation. We are all facing this current situation. So usually it present as multifocal consolidations in a peripheral distribution, posterior and peripheral. This is the posterior of the patient, the spine is seen, this is the anterior aspect of the patient. So this is the posterior predominance, posterior lateral and peripheral predominance. You see the peripheral predominance of these consolidations. So this is the classic appearance of the corona. So my take home message is, better than 1,000 days of diligent study is one day with a great teacher. Thank you so much for your attention. Your questions are welcome.